Good afternoon, and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is epilepsy and intellectual disability, and we're pleased to have as our speakers Dr. Beata Ruprecht, who's a pediatric epileptologist with Ascension, and Dr. Hussam Shaker, an adult epileptologist with Mercy Health Howenstein Neurosciences. Can each of you briefly introduce yourselves and talk a bit about your clinical and research interests and describe your experience with this topic? Dr. Ruprecht, would you like to start?
Good afternoon. Welcome, everyone, and thank you, Russ, for invitation. I am a pediatric neurologist as well as epileptologist, and I do practice both general pediatric neurology as well as epileptology at Ascension. I do see children, young adults, a little bit sometimes even more than older adults in my practice, but also neonates. So there's a broad variety of patients that I'm seeing. I do have special interest in epilepsy syndromes, both with the span from the youngest to the adult age, and both that are symptomatic or associated with intellectual disabilities or just idiopathic syndromes throughout the lifespan.
Okay, great. Well, we look forward to tapping into that experience today. And Dr. Shaker, can you introduce yourself?
Sure. Thank you for the invitation first. I'm Hussam Shaker. I'm adult epileptologist at Mercy Health St. Mary. I'm also a neurologist. I did my residency here in Grand Rapids and fellowship in Cleveland Clinic, fellowship in epilepsy. And my fellowship includes pediatric training and neonate. So I had some experience. I did extra year of training there. So I have some experience with patients with intellectual disability who are having epilepsy. Currently, I'm practicing only adult. I'm only seeing adult patients with epilepsy. So I'm still involved in research in Cleveland Clinic, and my biggest interest is surgical epilepsy. I'm here director of surgical epilepsy with stereotactic EEG, and I'm still doing research on fast activity and surgical epilepsy. Thank you.
Okay, great. So Dr. Ruprecht, the vast majority of intellectual disability is identified in childhood. Can you define the terms intellectual disability and developmental disability and discuss how and by whom intellectual disability is typically diagnosed?
Developmental disability is a very broad term, but basically implies the number of different conditions that can either involve mental or physical impairments, or sometimes actually it involves both, so it could be a combination of both mental and physical impairment. And there are different examples of that, like speed delays, hearing impairments, autism spectrum, cerebral palsy, and etc. On the other hand, if we are talking about intellectual disabilities, it means that a person's mental capacity is below normal, and this might be due to anything that imparts brain development even before the child has been born. Sometimes it can happen during the birth, or sometimes after birth. So usually these will be people whose IQs are lower than 70 according to the standardized testing for intelligence. So IQ lower than 70 will imply as somebody with intellectual disability. But also, in addition, it's not only our IQ that matters. It is also adjustments to the life, so other adaptations of the life. whether we are able to take care of our meals, grooming, house, able to keep a job. So that's what more defines intellectual disability in addition to intelligence. And about 1% of the population worldwide do have intellectual disabilities. And actually, if we compare this to prevalence of epilepsy, it's a similar number because another 1% of people do suffer from epilepsy. And I mean, putting this to kind of like a closer perspective, it's 1 in 26 people around us will develop epilepsy at some point, and the same 1 in 26 people around us does have some type of intellectual disability. A vast majority are mild, so these people are oftentimes still able to take care of themselves. And only about 3 to 4% are really severely impaired that will need sometimes, most of the time, 24-hour care. And about 10% of people will have moderate that may need some level of assistance. But again, vast majority are having just mild intellectual disability. And normal IQ is obviously above 70. More average is about 90 to 110. So if we are talking about numbers. Okay. And who diagnoses, whose role for diagnosis is, so intellectual disability should be diagnosed based on standardized testing. Sometimes there are clues from primary physician, pediatrician, or a family physician that a child does not develop normally, or there are some delays in development. The delays might be in motor development. The delays might be in speech or like social interactions. So pediatricians initially do some screenings during well checkups or when parents bring any concerns for development, and if some screening test is done initially by the primary physician, either pediatrician or a family physician. From there, usually these children are referred to subspecialties, so they can be referred to a neurology, they can be referred to developmental pediatrician, and again, broader evaluations are done by or by psychologists or by neuropsychologists, so with standardized testing. Some of the diagnoses can be made clinically, but in general, it's more you need a team of people to come up with diagnosis oftentimes.
Okay, great. So can you review some of the more common causes of intellectual disability in people with epilepsy? You referenced a couple in your comments, but can you talk about kind of what some of the more common causes are?
So common causes, one of the causes could be cerebral palsy. And a lot of other causes could be genetic. So, for example, like Down syndrome, babies with trisomy 21, or babies or younger individuals with Fragile X syndrome, Angelman. So, a lot of mutations, in our DNA can cause both intellectual disability, and also these people will also suffer often from epilepsy. Tuberous sclerosis is another one that vast majority will have epilepsy, and also they will suffer from intellectual disabilities. West syndrome, some of the developmental epileptic encephalopathies, and West syndrome is one of, it's a broad spectrum because it can have different etiologies, but with this syndrome, vast majority, over like 80% of patients will also have developmental disabilities, and they suffer from really intractable seizures oftentimes. Other developmental epileptic encephalopathies like Dravet syndrome or Lennox-Gastaut, these are also individuals that in about like 80-90%, sometimes almost like 100% of these patients will have both intellectual disabilities and seizures as well. So there are a lot of genetics involved here. Sometimes it's a metabolic cause. Sometimes it's a structural cause, like with cerebral palsy, where usually you have some brain malfunctioning that will cause, in addition of the motor impairment, problems with intelligence. There are also some inherited or like genetic and sometimes not genetic brain malformation, like focal cortical dysplasias or like lissencephaly. And so abnormalities in our brain development can cause intellectual disability and both epilepsies. There is a syndrome where you have where you are actually during the nighttime in electrographic status epilepticus. Seizures are not seen outside, but the brain fires all the time at night, and a lot of these patients also may suffer from intellectual problems. So there are a lot of causes, and I think more and more we are learning from better MRI techniques, better testing, especially with genetics.
Great. Now you mentioned ESES, or electrical status epilepticus during sleep. Is that considered, if that is treated effectively, and again, this is where you're having continuous abnormal electrical activity during sleep that is not manifesting as an actual seizure, but is kind of interfering with brain development. If that is treated effectively, is that reversible, or how often do you see kind of permanent changes in the brain that cause long-term intellectual disability?
Up to a certain extent, it is treatable, and sometimes you have good results with treatment, but oftentimes it is very difficult to get these brain waves with paroxysmal activity under control. And even though the brainwave activity can get under control, oftentimes you cannot help with the other developmental part. So this one is there is another syndrome on the spectrum with Landau-Kleffner syndrome that is associated with some kind of like a speech regression. So if you compare, and those kids as well will have seizures and abnormal activity during sleep. But for example, like kids with Landau-Kleffner syndrome, they seem to get better if you treat them appropriately with anti-seizure medications, where opposed to electrographic status in sleep may not be as great outcome as we would like to. So oftentimes, even though you treat the seizures and then the electrographic status, still you are left with a lot of other developmental and kind of like learning disabilities and intellectual problems, behavior.
Okay.
So probably there is some type of coexistence of both, and if you treat the one, it might get a little bit better, but not fully.
Okay. And this question is for both of you. Is epilepsy associated with intellectual disability more likely to be focal or generalized? And I guess, how does that compare with the overall prevalence of generalized versus focal epilepsies? And then among people with intellectual disability who have focal epilepsy, is there a higher prevalence of multifocal epilepsies than in those without intellectual disability? So if either of you have any information on kind of the prevalence or the likelihood of those different types of epilepsy, that'd be great.
Sure.
As far as okay.
No, go ahead.
far as pediatrics, so what we see in pediatrics is if this is just mild intellectual disability, more often the patients will have focal onset seizures. And this is what we see in general population as well. So focal onset seizures are more common, and I think that Dr. Shaker can talk about more what are the most common focal seizures in adults. But as the farther you go, the more severe developmental disability, the more severe developmental delay, then you start having more generalized symptomatic seizures, and then actually mixed seizures and a lot of seizures types. So then you switch more to generalized patterns of the seizures and multifocal that we call. So a lot of multifocal features on the EEG, different types of seizures as the severity of intellectual disability or developmental delay is worse.
Okay, great. And Dr. Shaker?
Yes. So in general, in epilepsy, we have like a clear classification. We have focal, we have generalized, which usually we say idiopathic, genetic. In intellectual disability patient, it's a little bit more tricky. So focal epilepsies predominate in those with mild intellectual disability, and those about like 69%. But symptomatic generalized epilepsy predominant in those with severe intellectual disability. And when we say symptomatic generalized, we mean most of the time that we are on the border in between. It's not 100% generalized epilepsy. It shares some characteristics of generalized epilepsy, especially on the EEG and some clinical features. At the same time, we still see some focalities here and there. So most of the time in adult epilepsy, when I have those patients, I spend a lot of time on understanding their clinical semiology, at the same time try to understand their EEG. Most of the time, I end up calling it a generalized and multifocal. And when I say that, I know that it's very severe and medication resistant epilepsy. So to put it together, when we have symptomatic generalized epilepsy, usually we see it in patients with severe intellectual disability. On the other side, when we say focal, only focal, so usually it has better prognosis and they have a clinically milder intellectual disability.
Okay. And in those cases where it's largely generalized, but there are some focal elements, is it basically that it's almost like there's two epilepsies coexisting at the same time? Like some seizures arise from a specific seizure focus, or more than one? One seizure might be from one focus, another might be from another, and other seizures have no clear onset or arise from deeper structures in the brain. Is that kind of how it works, or?
Yeah. So
okay.
A lot of reviews about these points you mentioned, because it's not clear it's 100% here or there, but based on EEG, most of the seizures, they look generalized with like diffuse onset on the EEG. Interictally, it looks multifocal. So you see predominantly at least 3 independent foci interictally. But when we come to the seizure, most of these patients, they have multiple seizure semiology, mostly tonic. In adults, we see them tonic seizure rather than atonic, and we see some myoclonic seizures. So yes, to answer your question, yes, I see a lot of mixed features on EEG and clinically.
Okay. And to what extent is neuropsychological evaluation used in people with epilepsy and intellectual disability in both pediatric and adult patients? Dr. Ruprecht, you mentioned that sometimes it's used for that initial diagnosis, but seems like it could be very valuable to do this periodically throughout the lifespan, but I suspect that maybe it may be underutilized. Can you share your thoughts on the role of neuropsychological evaluation in people with epilepsy and intellectual disability?
I completely agree with you, Raz, that it's probably underutilized, and sometimes there are some barriers to get this testing done. Overall, I myself sometimes do have struggles to get the testing, but I would love to have neuropsychometric testing done in every patient with epilepsy, and not even necessarily that have developmental disabilities or intellectual disabilities. I think everyone should have that, but especially patients who do have intellectual disabilities. It can show us a lot. It can, guide you what type of therapy the patient may be undergoing, what skills you can get, which areas you are better, which areas are your weaknesses, and which areas are your strengths. And if we are able to identify that, then we can go on the route. What else you can make to have my synapses in my brain better? And the ones that are kind of lazy and they forgot what they have to do, maybe we can supplement them with the others that are very strong. So I think, and again, I mean, this can change. So this probably should be repeated at some point. I guess repetition of the testing such that should be individualized based on specific indications. Oftentimes, and I know that Shaker can talk about this more, we use neuropsychometric testing, especially before somebody is going to have be possible candidate for epilepsy surgery. But even though if you are not going for the surgery, this can be a very helpful additional diagnostic tool for us how to move forward with life.
Right. And Dr. Shaker, I imagine it's even used less in adults and probably harder to get covered by insurance. But what are your thoughts on neuropsychological evaluation?
Correct. I agree with both of you. It's and unfortunately it's underutilized. I always tell residents here that when we examine our patient in the clinic, we look only for something clear and obvious. It's like primary cortices. So I examine the motor, I examine sensory, hearing, visual. So I do something to look for any problem with the primary cortices. But what about the association cortices, which is the most of our brain and is very complex? So to me, I don't see that until I spend a lot of time with the patient. So that's why in my practice here, and I feel the neuropsychological testing is very, very helpful. I have very great relationship with them because I always learn from them, and they give me more information that I don't know about my patient. I learn more about my patient after they do the neuropsychological testing. I always push for full battery, and it's about 3 to 4 hours testing. And can you imagine how much data I will get about all aspects, function of the brain, especially if there is underlying like even mood I'm unaware of, there's some anxiety, and besides and all other functioning. Regarding surgeries, which is now, it's become like the hot topic in pediatric, especially with people with intellectual disability, because if you find the lesion early, the outcome is great to decrease the severity of intellectual disability, especially in like diagnosis like tuberous sclerosis. If I find the right lesion and I remove it, even if I have multiple lesions, I find the one that's very active, remove it, I would have a great outcome. So neuropsychological testing plays like a huge role before the surgery to give me the pre-morbid disability, where I am before the surgery, what should I expect after the surgery, how is the language doing, how is the memory doing, how is the visual spatial doing. So I think neuropsychological testing is critical in our practice.
Great. And as far as like insurance coverage, I know that can be a barrier. How often do you find that that's a barrier to getting neuropsychological testing, particularly in adults?
In adult, what I have been doing now, I get some pushback, but I always ask for peer-to-peer, and I push for it, and I talk to the neuropsychology PhDs people here, and we try to advocate for the patient. Now we are having a team to have like good documentation to defend our reasoning why we are ordering the neuropsychological testing. It's not only underutilized, but people, they are unaware of the importance of that. So once you talk to them, even the insurance company, you tell them this is what we're going to do, this is the benefit, this is the lacking of exam that we have. They so far I have success getting the exam done. The other problem that we have actually, it's the scheduling, because, per day they can do only one or two because like they spend 4 hours on one patient. So also the scheduling, we cannot do it within like 2 to 3 months. So it takes a long time to do it.
Right. That makes sense. But yeah, it sounds like if you have an epileptologist who's willing to advocate for it, that you can usually or often get it covered. So that's great. So beyond IQ, people with epilepsy and intellectual disability can also have specific learning disabilities, memory problems, ADHD, executive function disorder, problems with expressive or receptive language, and a lot more. So while IQ is generally not modifiable, many of these other cognitive functions may be. So do you think that sometimes these other cognitive functions are sometimes obscured by the intellectual disability and not enough is done to assess or address them? And if so, what can patients and families do to appropriately kind of prioritize them when working with their healthcare team?
So if I can just say something, yes, I think oftentimes they are obscure because, as Dr. Shaker said, we don't see this oftentimes, when we are spending time with the patient. So they are a little bit underneath, and sometimes kind of brushed off by everyone around. Sometimes even parents do not recognize that the child's irritable behavior or like denial to do stuff, maybe just because they have anxiety, or maybe they just have ADHD, or maybe they really have a mood disorder, as opposed to just being mean or bad. And again, neuropsychometric testing might be the great tool to try to kind of surface all these little things that actually may be a very big things. If you address them, a lot of times, oh wow, I mean, it's another child, it's another teenager, and then sometimes parents are amazed. Sometimes teachers cannot recognize the student at school who all of a sudden now is polite, follows commands. So I guess everyone has to be very open to try to modify and try to look for what could be other reasons why, for example, my child is behaving like that. It doesn't have to be medication side effects, but be open. Talk to school. Talk to everyone around. Talk actually to your other parents who have children with similar conditions. And then again, therapy would be also very important to be implemented. So I think that all these things should be taken into account.
All right. Dr. Shaker, any thoughts you'd like to add?
Yes, I agree with Dr. Ruprecht. So people in general, they like to have like one number go around it. So that's why most people, they use IQ, or let's go by the number. If it's below this, it's above this. But it's more complex than that. And with patients with intellectual disability, most of them, and maybe more, all of them, if they go beyond like the mild to moderate, they will have specific learning disability, they have a memory issue, they have ADHD, they have executive functioning, they will have the language issue. So sometimes we have probably to look for other problems if the patient cannot express what they want. Especially when I talk to the family, I ask, is there any new behavior? Because they know the patient more than me. They spend time with the patient, and they know everything. Like, it's interesting. I say, oh, how do you know he's hungry? He said, oh, he looks to the right. How do you know he wants water? So, oh, he will do this. He will move his hand in this way. So they know the patient more than me, but I always emphasize on the, is there any new behavior? It might reflect there is underlying pain or there's underlying infection that the patient cannot express their problem. Is there new changes in the sleep habit? Is the patient sleeping more? Is it sleeping less? Is there more anxiety beyond that? So all these questions I try to target to the caregiver or the parents, whoever taking care of the patient. And sometimes it's not easy to find the answer for that. Sometimes we just try to find, like, in general what's going on. Maybe I'll do like a blood test. I might ask to do like EEG, is the patient in status? Because if there is a new behavior I don't have explanation for. Yeah.
Right. Right. And in cases like, ADHD, and again, I think this is probably the case across the board, even in people without epilepsy, is that like in adults with ADHD, I think there tends to be an assumption that this is a childhood problem. But, kids with ADHD often grow up to be adults with ADHD. And there are many adults who maybe have that and it was never diagnosed early on, and are living with that. So like, that's, one example of, if that's identified in someone with an intellectual disability and epilepsy, that's something that's treatable. Stimulant medications or other medications for ADHD can be safely used, with anti-seizure medications, correct?
Correct. And interestingly about you mentioned about ADHD, some people, they have the stigma that ADHD medication worsen epilepsy, and you can see a lot of literature in the past. Recently, thank God, in 2018, 2019, there is a two big trial in Sweden and in the United States, multi-center, that showed clear data that ADHD medication, they are not associated with development of epilepsy. And not only that, they showed it decreased the number of seizures, and a lot of explanation for that. So coming back to your question, yes, I have this conversation and I tell them, we have a lot of comorbidities with not only epilepsy, and if I treat the comorbidities, things will get better. So if I treat ADHD, maybe things will get better. I cannot blame everything to either epilepsy or either, the patient has intellectual disability. No, I will always look for something is treatable before I look for something I cannot treat. So it's easy. One medication I can help with concentration or the excessive motor. So it will be awesome. I always have this conversation about ADHD.
Great. Okay, so many people who have epilepsy and intellectual disability also have a wide range of physical health challenges. What are some of the more common challenges you see in patients, and how do these physical conditions or symptoms impact seizure control and medication selection?
So let me just talk about population with cerebral palsy, because those are the ones that kind of suffer a lot from mobility issues. So kids will have problems with bone health because they are not mobile. They are more prone to fractures. In addition, they are more prone to sleep disorders. Also, there are a lot of GI issues in women. Also, GYN problems with periods, with menses. a lot of respiratory issues and orthopedic concerns as well. So this all can impact the treatment of epilepsy, and there are challenges. I agree. However, we can do something about it. There are a lot of technical advantages right now that kids have, mobile devices that, especially the ones who don't have such a severe cerebral palsy, so maybe like diplegia, which is really like milder form of cerebral palsy. They can be implemented. These kids usually do not have any difficulties with upper extremities, just lower extremities might be affected. So these devices can be implemented, but even though for kids who have spastic quadriplegic, where upper and lower extremities are compromised, there are a lot of like new chairs that and they move around, and the kids sometimes may learn how to move by themselves as well. As far as getting the medicine, it might be a problem. So medicine for the seizure, how are you going to give the medicine for somebody who cannot swallow or somebody who has aversion? A lot of kids will have G-tubes. So in this instance, it might be the easiest way just to get the medication via G-tube. But you also need to keep in mind whether this medication is compatible with G-tube. But if they cannot swallow tablets, then we can offer liquid. There are also chewable medications. There are sprinkles. There are intranasal medicines. And there are some that can orally disintegrate. So that there are a lot of challenges that patients may have, especially with physical impairments. But on the other hand, there are also some improvements that you can overcome that.
Right, and you mentioned kids with G-tubes. Have you found that that is a situation where ketogenic therapies can be effective because it's the choice of food is less important, and it's a little easier to potentially administer ketogenic therapies that way?
Yes, excellent point, Ross. Yes, because basically a lot of time ketogenic diet may not be very palatable, so not everyone likes to eat all this fatty stuff. So it's very easy actually for kids. They are actually the best candidates for being for compliance with ketogenic diet. You don't have to worry about non-compliance for a kiddo who has G-tube placement. So yes, so this would be a very good choice, and we know that ketogenic diet can be very effective and nearly the same as anti-seizure medicines in controlling seizures. Obviously, has its own side effects, and you have to be mindful of that, and it will require blood work. But yes, this would be really like an excellent option for some patients.
Yeah, okay. And Dr. Shaker, just in the adult population, can you maybe give some examples of some of the more common physical symptoms or conditions that you have to navigate in terms of, your treatment choices and seizure control and those types of things?
Sure. The same thing. It's common in adult population. I can add to what Dr. Ruprecht mentioned. In adults, also we pay attention more to sleep disorders. So 30 to 60% of patients with intellectual disability, they have some underlying sleep disorder, and maybe this is like easily treated with some like CPAP or whatever. We can't find the reason why the insomnia or the excessive sleep, whatever the problem they have. So I always ask about that. GI issues also is problematic, as she mentioned. So you have to be very careful about the doses of medication. I always look to the liver enzyme function, because the way medication will be metabolized may be a little bit different from healthy patients. constipation is very common in this population. So sometimes I push, I either like communicate with the primary care physician or myself. I still remember some of my like internal medicine year. So I start with like safe medication for constipation if it helps. Keep attention also to respiratory if there is any underlying respiratory issues or episodes of apnea. So it changes my option for medication. So I stay away from any benzos or phenobarb or any medications that might suppress respiratory function. Dr. Ruprecht already covered the topic of like bone health, vitamin D, calcium. Sometimes if the spasticity is very bad, I also add some medication for that to help in this situation. Sometimes I advocate for Botox. I refer them to movement disorder or neuromuscular clinic if I feel the spasticity is very, very, very bad and the family they like recently got worse or something like this. So a lot of like different systems we got involved to make sure everything is going well. And for ketogenic diet in adults, we have a clinic for that, but I can tell you it's a little bit like less successful compared to the pediatric population when they have the real ketogenic diet compared to the adult.
Right. Right, and certainly, the modified Atkins or low glycemic index treatments are more likely to be successful in adult populations. But yeah. Just a quick question, a follow-up question about when you mentioned GI issues and sleep disorders. Are there, with the vagus nerve stimulator, are there any contraindications in terms of either people who have sleep apnea or who have GERD or any or swallowing difficulties or anything along those lines? What things would you physically, as far as physical conditions or symptoms, would you have to look out for if you were considering the vagus nerve stimulator as an option?
Yes. So I always involve with me in our team the sleep doctor, and also I have speech therapy before I move to VNS. And you mentioned VNS. We use it very frequently in this population because unfortunately most of this epilepsy is refractory, intractable. So we run out of medication, like 4 or 5 medications, and after that we add VNS. But yes, I do the screening for the speech, swallowing. People, they get more concerned. They read about VNS and the vagus nerve about the heart issues, but data shows that it has nothing to do with bradycardia, tachycardia. So I always do, answering your question, the speech, language, and the sleep evaluation right before moving to the VNS implantation.
Okay. So the presence of some of these physical conditions combined with intractable seizures, which may involve falls in many cases, can put people with epilepsy at higher risk of injury and death. Can you talk about some precautions and other measures to reduce these risks in people with epilepsy and intellectual disability?
So for pediatrics, we oftentimes prescribe helmets for kids who fall a lot and may have a seizure. So this is just for prevention of the head injury. But in addition, you may suffer from the fractures. Not so much in pediatrics, though. I think this will be more for adult population when they just fracture, the femur or the shoulder. But sometimes it does happen in pediatrics as well. As much as possible, we'll try to inform the caregiver to protect the patient. So, for example, when they are asleep, make sure that this person does not sleep on a high bed, or there are some barriers around that the patient does not fall at night on the floor and then suffer from the head trauma or other traumas. Kids with frequent like atonic seizures or tonic seizures when they just fall, drop to the floor. Oftentimes may suffer from the injuries, and then again these patients will benefit from helmets. We need to be very vigilant about burns. So we always say that try to have distance, not to be close to like the places that you can burn yourself. Also drowning, that's another big issue for people with epilepsy or the additional developmental disabilities. So we recommend that they don't really take baths on their own, and they will take shower instead of bath. And you don't want to have these kind of like a pop up and down drains in the shower. That's like all of a sudden, the tap will be there and the water will come up, and it may be life-threatening. So careful supervision with any of those activities. What about like swimming? That's another thing. Like kids love to swim, and you cannot tell that the child that you cannot go and swim. So direct supervision one-on-one, and life jackets. This might be very helpful to avoid any type of injury. So as much as possible, we want to minimize the risks of that. And yes, there is increased risk of death for people with epilepsy, especially with intractable epilepsy. So like sudden unexpected death in epilepsy SUDEP. In pediatrics exists as well. It is very rare, but again, it's more somebody who has intractable epilepsy, and especially kids with Dravet syndrome. They are really at higher risk for SUDEP. So having some supervision, at night with the person or staying next to the patient, it is actually the most helpful thing that you can do, because you can move it, you can put it on side. And you can actually prevent that.
Okay, great.
The other thing.
Go ahead. Sorry.
The other thing I didn't mention, but a lot of times we do say that devices like apnea monitors or like another monitors that will detect movement or heart rate might be helpful for this population. There are more and more seizure detection devices with smartwatches, Empatica in place. I think some of them are partially even covered. I had one of my patients that insurance was able to cover a portion of the watch. So those are another extra things that you can do to minimize the possible risk of injuries and death.
Okay, great. Dr. Shaker, anything that you found particularly helpful in terms of safety precautions or methods to reduce risk in adult patients?
Dr. Ruprecht covered it very well. In adults, we don't have a lot of atonic seizures, but I still recommend helmet if they have like mild intellectual disability for even biking, bicycle, whatever. So I ask them continue to wear it, even if they are like confident. I always emphasize on that, to wear it. Sleep apnea treatment is also very important, especially if the sleep study report showed that like multiple episodes of apnea during sleep. Regarding seizure detection, I recommend to all my patients like smartwatches. It's very helpful and also gives us idea. Some of these seizures, they followed by asystole. So if they have the smartwatches, sometimes they have the features to give you like EKG traces. So if you see that, you push, like I have one or two patients, I called cardiologists maybe to put like pacemaker or something to avoid having asystole, prolonged asystole. I know it's like there is a lot of debate about that. What I found also interesting, and I have noticed that when I was doing ambulatory EEGs from home, that patients, they have dogs that they figured when the patient's having seizures, so they start barking. And I have one patient who told me he does not know he has seizure until his dog barks, and it was true when I recorded his seizure from home. So he feels confused, and the dog doing something to the patient, and the patient knows that he's having seizures, and the patient did not tell if it's before or after because the patient was confused and he was living alone. So it was all very interesting, like trained dogs for the seizure. Pulse oximeter, because some patients will have apnea, is helpful. We're still looking for some more dedicated devices only for epilepsy patients, regardless if the patient like intellectual disability or not. But the risk of suited for people with frequent generalized tonic-clonic seizure more than 3 a year, it's getting high and high. So I think in the future we need more research for developing very easy technique to capture seizures and notify caregiver.
Right. And do you find that the use of rescue medications now that there are intranasal formulations is that they're being prescribed more often in adults than they used to?
It's still more prescribed in peds. When I was treating pediatric patients, I use it more. But now, if I feel like the other method, like clonazepam, the patient don't feel comfortable or it's not helpful, I move to the nasal midazolam, or recently there is also diazepam came out. I did not use it yet. I did not prescribe it yet.
Okay. Because people with epilepsy and intellectual disability often have to manage seizures, other physical conditions, cognitive challenges, and mental or behavioral health issues, the healthcare team can include a lot of different providers and specialists. And coordinating that care can be a challenge, particularly if you're using providers from multiple health systems or practices. What are just some general keys to successful care coordination? And who often takes the lead in that process? Like, is it the primary care physician, the neurologist, the parent or patient themselves?
For speaking for pediatrics, I think that general pediatrician, or this could be also the family physician, should be so-called coordinator in managing, the care. However, it involves, as you said, it's often not easy to do, and oftentimes the more complicated problems patients have, then it even that's why it gets complicated. The one key thing is communication. So all these people, they have to communicate together, and oftentimes parents actually are so frustrated with that parents will bring you like a binder of every subspecialties, and then they will tell you, okay, we need to send this letter to the doctor so-and-so, and doctor so-and-so, and doctor so-and-so. So I do see that parents sometimes actually are the coordinator, but in fact, I think it should be more primary physician taking lead on that. Oftentimes, we try to help as much as possible. Again, communication will be the key. So sending all the notes to different providers, and also getting them from these people too. So we are all on the same page. We are not interfering with medications, for example, prescribed by a mental health provider. So like a psychiatrist will prescribe the medicine that we may feel that, well, maybe this medicine is kind of not the greatest one in the setting, but the psychiatrist for some reason didn't look more to adapt all the other things. So I think communications, having a good relationship with all the subspecialties is the key, and it's not always easy. Right.
Dr. Shaker, any thoughts you want to add?
Yeah, it's as Dr. Ruprecht mentioned, communication. I think this is the key to take care of this population, this like difficult population of patients. And now we have the electronic medical record that if we are using the same electronic medical record, it should be a little bit easier. I agree that the process should start from primary care physician, then neurologist. We should have a clear role, I think, in medication prescription, because sometimes I feel like some subspecialist waiting, like especially the overlap, like psychiatry, neurology, sometimes PCP. So what I do, I usually, once I see the patient for the first time, I communicate with the primary care physician or whoever referred the patient. I tell, I will take over for these medication refills, taking care of them. Sometimes if the patient, they don't have psychiatrist, I take care of like antidepressant medication, but for antipsychotic behavioral, I'm very clear that it should come from mental health department, and I always communicate with them. So it's kind of like multidisciplinary, because you need you have like at least 3 different subspecialists, but and you need someone to coordinate. Parents should be on the same page with everyone. Sometimes we forget, but parents will remind us about that. So to answer your question, yes, I think it should start from primary care physician, then neurologist.
Okay, great. So the transition from pediatric epilepsy care to adult epilepsy care should be a long process that begins in early adolescence and continues until the transfer of care. The presence of an intellectual disability often changes several things about that process. Can each of you talk a bit about some of the key steps and considerations in preparing for the successful transition from pediatric to adult neurology for those with epilepsy and intellectual disability?
So such process should start fairly early. Doesn't mean that you have to transition your care when you are 18 or even like 21. It doesn't mean, but you need to have a plan, what you are going to do, what are the long-term plans, and also rescue plans. The more severe and more complicated is your child or the patient with epilepsy, I think the process needs to even be started even sooner, and we need to have a plan for it. Again, communication is the key, but we try to keep patients' history updated every time that they come to the clinic. Medications that worked or didn't work, side effects. This is very important to be implemented in such plan. For parents taking care of children with really severe developmental disabilities, they need to have guardianships in place. And they also need to think like in the future what will happen if, they age. And what happens if they are not here? So who will take care of the children then? So those are really like very significant things that the parents and care providers sometimes have to sit and discuss and put things in paper. So I always encourage parents to keep, original binders for themselves, copies for other subspecialties. Oftentimes establishing a trust before you transition. Actually, this is not really about the transition, but just for somebody who has challenges, when the time comes for the parent that may not be available anymore, it is always nice that the patient will have some type of economic trust in place as well. So sometimes lawyer may need to be involved in that, but overall, successful care coordination is, again, if you're transitioning from pediatrics to adult, it involves communication. Ideally, you would like to have an adult person, like the name of the person who will take care. There are some challenges if patients will move from one state to the other or to other like remote areas. Then again, we'll try to kind of look for people who may be out there and then take over. Again, it's a long process, and expectations have to be met on both sides, especially on the parent side, that adults may clinic may work a little bit different. They involve more autonomy from the patient. Sometimes they require that the patient will be going there. Parents may not be always there. So it's a little bit different, and it's a long learning process. It can be done, but it involves a lot of other people.
Yeah. Dr. Shaker, when you're receiving a patient from a pediatric provider who has an intellectual disability, what are some of the key predictors of a successful transition? You know, when you are getting a new patient who's just entering adult care.
Yeah. So I like the term transition, not transfer, that you use transition. I like it because it's easy to transfer patients. You just set appointment with the adult epileptologist or neurologist and send letter of referral and say goodbye. But we are here looking for transition of care. So you don't need any interruption. And it's very difficult sometimes, and you need to work with the team to talk to the pediatric neurologist to better understand the patient. I think pediatric epileptologists are doing a great job, and in my practice here, we are working on to have a clinic for transition because we feel there is a gap. When you ask me, there is a gap. Sometimes we have it. We need some time to get educated more about the patient, about the treatment, and we need to build very close and comfortable relationship with the parents with the time. So when I'm waiting for someone to come, like I expect it to be a little bit earlier than 18. Usually I prefer it to be like around 16, just to have some overlap time, to be familiar with the condition. I like to have detailed note about like summarizing all medications that have been used, what medication I should not use, any specific note about this patient or the family. So I think building relationship also with pediatric epileptologists for us, it's critical. So in my hospital, we don't have pediatric, but other hospitals, but I know all of them. I always call them to make sure I don't miss anything, especially in the first visit, and they do a great job summarizing everything for me. Also, we don't need to have like time with gap in refills. So we should be clear from the beginning on the refill. So patient, they don't, especially with patient with refractory epilepsy, you don't want to have any days without medication to prevent any status epilepticus.
Right. So now I looked at the American Board of Psychiatry and Neurology website, and we have 79 neurologists in Michigan who are board certified in epilepsy, but we have 0 neurologists who are board certified in neurodevelopmental disabilities. So does that accurately reflect kind of a lack of expertise in this area in Michigan, or are there other ways of finding neurologists in Michigan who have specialized knowledge or experience in intellectual disability?
Oh, this is a great question, Ross. Well, partially you might be correct. I don't think that neurodevelopmental disability subspecialty has been advertised to us.
Okay.
At least when I was in training, I did not really have a lot of knowledge about that. Mm-hmm. So it's fairly, I would say, rare, as I just mentioned. Okay, so none, and I don't really know anyone else either, even like outside of the state, who would specialize in that. Sometimes the people do specialize in, so people who finish pediatrics, then they go to like developmental pediatrician. So they become like a developmental pediatrician. This is additional like training for about 3 years. So I do know a couple of people who do have this subspecialty, and it's kind of almost like mimics to me, like almost neurodevelopmental
right.
subspecialty in that area. But yes,
you mentioned that earlier. And I was not aware that developmental pediatrician was a thing, so that's good to know that is an option.
Yes,
So.
yes.
And
And
Dr.
that
Shaker,
is,
any? Oh, go ahead. Sorry.
oh, no, I was just going to say that University of Michigan does offer the training for developmental pediatrician. It's a 3-year program.
Great. Dr. Shaker, any thoughts on that or?
Yeah, it's very interesting that I don't know any, as you mentioned, any neurologists who specialize in neurodevelopmental disability, not only in Michigan, like across states. I have noticed when I did my residency fellowship that, as Dr. Ruprecht mentioned, they come from like pediatric. Do you hear me?
Yep.
Yes.
Oh, sorry. They come from pediatric training, and I look to I think neurology. That there is a fellowship, but most of them they come from pediatric. I don't know if it's not well advertised, and I don't know if people honestly maybe they concerned about the job opportunity because they are not familiar with that. So you need someone who is dedicated to do that. But it's very, very interesting to have a neurologist who is specialized in neurodevelopmental disability.
Right. So probably the best way to find out is, if you're searching for an epileptologist who also has experience with that, would simply be to ask them about their experience with that population, probably, or check. Some might mention it in their bio on a website. But I would guess that's probably the key in selecting an epileptologist or neurologist who has familiarity with that, is just simply asking, do you see a lot of patients with in that area?
Yeah.
Yes.
Yeah. Okay. So because some people with intellectual disabilities also have communication difficulties, that can create challenges in tracking and managing both seizures and side effects. For example, the details of a focal aware or simple partial seizure may be difficult to communicate. And then that also may be the case with subtle or internally experienced medication side effects as well. So what are some strategies for parents and other caregivers in such cases? I know we kind of referenced this earlier about sometimes just simple, parents can recognize simple head movements or expressions or things that communicate a certain feeling or concern. But can you talk a little bit more about how to recognize seizures and side effects in people who are nonverbal or who have limited communication?
Sometimes they can be very subtle in pediatrics, and sometimes it's a very challenging thing to recognize that, because the kids with intellectual disabilities have also other movement disorders, a lot of stereotypy, a lot of for example, a hand flapping or lip smacking that can be easily confused with seizures. In these instances, when we really have no way, I always ask parents to make a video, if possible, of these movements. And sometimes, based on the video, it can give you a clue whether you are leaning more towards just stereotypy behavior, or simple a movement disorder, a tic or something else, not a seizure. But sometimes it can also guide you that, oh wow, maybe we should actually get EEG for confirmation. So EEG would be a good test, if feasible, to kind of sort it out whether this might be whether the patient might be experiencing a subtle seizures. Sometimes very subtle changes in behavior, like Dr. Shaker mentioned, or changes in sleep, or for example, if that they stop eating, or they hyper eating. Or I have one patient who is always, before he has a seizure, he is just munching on pizza, and he eats pizza for a couple of days. And initially, mom thought that this is oh my gosh, what is he doing? But this is a exactly the same behavior that the child is experiencing. He's just overeating on the pizza. Sometimes, changes in autonomics, like increased heart rate or like sweating, it might be giving you a clue that maybe this is a autonomic sign of a seizure. As far as side effects, it can be also difficult to recognize. Sometimes getting a blood work might be helpful. But again, those are very, very subtle things that I agree. It is always difficult to choose out. As far as the side effects, it is possible that getting a blood work, as I mentioned before, might be helpful.
Yeah, that makes sense. And Dr. Shaker, any tips that you have?
So first, for myself, I try to get the baseline to better understand the functional status of the patient, and I ask the family to tell me so we both on the same page about the patient baseline. Because if the patient have anything new, we know what is the baseline, so the mood, sleep, movement, quality of life, activity. Then so the parent or the caregiver, they know the patient more than me. So I always ask them any new movement or any new changes in behavioral or changes in the sleep. These 3 points I always ask the family to keep eye on. If one of these has changed, to let me know. The idea of videos is very, very nice. I always ask them if there is any new movement, and just to spare a trip, especially if people they live far away. So video is very, very easy to be done, and you can make the call sometime. Sometimes if you see it and it's very frequent, I ask to bring patient to the hospital. If I'm very concerned, I do epilepsy monitoring unit for those patients. If when I start medication, I always spend time on the side effects. If I feel I'm not sure if it's side effects or not, I quickly order levels for medication, especially that medication that's well known to cause side effects. So it's not easy. It's not easy most of the time, but we try to work it out by either doing EEG, sending videos, doing blood tests, try to rule out infection, all these steps just to avoid missing seizures or any new changes in their health.
Right. Okay. Just one last question, as I'm noticing the time. I want to make sure we have time for questions. But people with intellectual disabilities are at increased risk for dementia, and less is known about how epilepsy affects dementia risk, but there is some evidence to suggest that it might increase risk as well. With this in mind, Dr. Shaker, what screenings should be done, and what should family members be looking for? And then what, if anything, can be done to reduce the risk of dementia in adults with epilepsy and intellectual disability?
Yes. So the increased risk for, for example, Alzheimer's disease in patients with Down, definitely the relationship is well established. So we know that there is a data for that, and that starts around age 30. So in non-Down syndrome intellectual disability patients or other form, the average dementia age onset is 10 years prior to that experience in general population. So usually we start around late 30s. We start clinically. The presentation is not straightforward compared to the healthy population. So it's most of the time it starts with behavioral, personality, decline in executive functioning, before having the memory issues. So I always ask about behavioral, personality, executive. Then I do the standard dementia workup, but it's not straightforward regarding the examination because this is specific population. So the diagnosis in this population requires establishing longitudinal declines in their functioning. Ideally, it requires at least 3 sequential assessment. So I always get a baseline, to answer your question, baseline neuropsychological testing, then I moved to annually checklist. I found one interesting online called Carer Report Checklist. I use it sometime in my clinic, and I try every annual visit to go over it so I don't miss cognitive impairment. As I mentioned, it starts earlier compared to the general population.
Okay, thanks. All right, so we're going to go ahead and open it up for questions. And let me just switch modes here. And I just remind people to, if you're not asking a question or making a comment, to please keep your line muted. So hold on a second here. Okay, who would like to get us started with a question?
This is Hannah.
Okay.
Can you hear me?
Yeah, go ahead.
I am curious if there's a frequency at which it would be recommended to get neuropsychological testing, just generally. And then also, I guess a little bit more specifically, my husband has epilepsy and had lost his disability insurance just recently. I didn't know if it would make sense to get the neuropsych testing to potentially, we didn't appeal it, but to potentially reapply.
Okay, and Dr. Shaker, since this is an adult question, your thoughts on how often adults who maybe have some apparent cognitive difficulties with their epilepsy, how often they should get neuropsychological testing, and whether that can be helpful in establishing eligibility for Social Security disability benefits.
Yes. So doing neuropsychological testing in patients with intellectual disability, in my eyes, it has lower threshold. So I don't wait long as I do with general population with epilepsy. So the threshold is low to do the testing. As I mentioned, if the patient has Down syndrome, I start around 30 years old. I do baseline neuropsychological testing. If other forms of intellectual disability, I start around age 40, unless there's something specific or there's some severe decline or something happen, then yes, I push for it. And it's also very helpful for disability. So because if I have a baseline, this is all, I mentioned that multiple times, having baseline is very helpful for the future, just to compare all aspects, all domains, where they were a couple of years ago and where are we now. If we see a clear decline, it helps to getting going to disability. If I feel are stable, it's reassurance for the patient and for the family that things are still stable because we have baseline for neuropsychological testing.
Right. And certainly, having, if you're trying to make the case for eligibility, it's often not just a single condition that qualifies you, so it could be a combination of, refractory seizures and cognitive difficulties and possibly, mental health issues or physical conditions. So kind of the more data and evidence you have, the more you can kind of make that case. So, okay, other questions?
Hey, Russ, this is Karen.
Yeah.
The was talking about difficulty, you might have difficulty swallowing when I'm eating. Would that be from the medication, or could it be just epilepsy?
Okay. Swallowing difficulties, is that a possible side effect of an anti-seizure medication? Is that, or is that likely due to something else? Dr. Shaker, do you have any thoughts on that about swallowing difficulties? Have you heard of that as being a medication side effect ever?
It's very uncommon to have swallowing difficulty as a side effect from any of seizure medications. So I would do investigation to see if there's underlying cause of the swallowing difficulty to go to primary care physician with the right referral to the subspecialist, or maybe need like swallowing study with a speech therapy or GI to see what's going on. But I doubt, I cannot be 100% sure, but I doubt it's related to any of anti-seizure medication.
Because I've had every test you can think of, and everything comes back negative. So, but my other question is too, I'm an expert on falling all the time, and it's not because of a seizure. I just keep losing my balance. So I'm starting to use a cane. What else could I do or help keep me from falling constantly?
Yeah, I think that would be another question for a general practitioner, because there can be so many different things that contribute to balance issues or falling, and if you've established that it's not seizures and it's not medication side effects, then it's a matter of kind of ruling out other possible things, symptoms or conditions. But other questions about epilepsy and intellectual disabilities? I know we're kind of short on time, so I just want to make sure. Does anyone else have questions related to epilepsy and intellectual disability?
Hi, I'm Holly. I have a question.
Yeah.
My question is okay, so my daughter is 15. She was diagnosed when she was 5. And our biggest thing is memory. She gets really good grades, but when she takes tests, she bombs them. And we've tried putting information on a note card, but that doesn't seem to work with her. I've tried studying with her. I don't know how to help improve her memory when it comes to knowledge, because obviously memory is an issue when it's epilepsy.
Right. Go ahead.
I think that she might benefit if she hasn't had any formal testing done for memory. This might be the time to go ahead and try to get this testing done. So, based on the testing, it can be determined where is exactly the problem. Does she have trouble with remembering? Is this something with long-term memory, short-term memory? Is this processing speed? So I think that the testing might help, and then whatever areas are kind of missing here or underdeveloped, then developing the skill how to go around it might help with the testing strategy. And also, oftentimes, if such testing shows some impairment, you can ask for specific arrangements for your daughter, like 504 plan or like IEP, that should be available.
She has an IEP. I have a really big problem with the school because they don't give you really good. I don't think they have very many epilepsy kids there. And so I don't know I don't think they know, when I say, she has a memory issue, they can't come up with it, because I got the neuro testing done. She was diagnosed with ADHD and expressive language disorder. And reading comprehension is really, really weak. And so we have the IEP. Sometimes it's hard to get them to accommodate to it, because they'll say, oh, this or that, and a lot of everything. Because of COVID, I'm so sick of hearing that. That's one of the reasons they can't accommodate. Because of COVID, really? But I took that testing. I don't know if maybe some form of therapy would help her. They never came back with any type of memory issues, but I don't know how they would tested, because like I said, her homework's really good. She gets A's and B's, but when you look at her test scores, that's where you're holding the information. I said, I go, if she's failing the test, she's not learning what you're teaching her because she is taking, because she's not learning, because the tests are what you learn. And we've tried note cards, we've tried everything, and I don't know where to get, how to help her with her memory, how to improve it, or
Mm-hmm.
we're going. Go ahead.
Mm-hmm. Has she been tried on any medicine for ADHD?
No, she's drug resistant on top of everything. She has an autoimmune disease where the inflammation is basically from the inside out. And then, so she's already taking a lot of medications. And one thing I've noticed with the medications is when she wakes up and she has absence seizures along with Javangen syndrome. And when she wakes up, I see the seizures mainly in the morning. And her eyes are super dilated. And I've asked my neurologist about that, and they said, oh, go see the eye doctor. Go to the eye doctor. Eye doctor says she's fine. So we're having a hard time controlling the seizures, and she's very drug resistant because she was on ethosuximide for 8 years, and then she developed a drug resistant to it. And then we switched her to Onfi, and now she's on Fycompa. But anytime we try to raise any of the medications, she goes straight up into allergic reaction of hives, burning from the inside out, itching and burning, like it gets bad.
Mhm. Mhm. Well, if she's having a lot of seizures, this might also impact the learning and then the memory. So a lot of things can play role. Why she's not learning. So ideally, you would like to have seizures under the best control as possible. And then if seizures are well controlled, then maybe you can move into other strategies. Having a good neuropsychologist on site might be very, very helpful because they are usually the ones, like the therapists, who can make a plan. What are the other strategies? What school can do another way, like teach me different way. I learn differently. So what are other options for getting the learning that she needs to get?
Okay.
And that's one thing I've noticed in that, sometimes I've been able to read neuropsychological reports, and the assessment side of it is very detailed, but then the recommendations side of it sometimes is like a single paragraph at the end. Like,
exactly.
Here are some strategies, and it seems like that's a lot of times what parents and adults who are struggling with any kind of cognitive issues are really looking for is, okay, I have these problems, now what do I do about it on a day-to-day basis? And I think that's just, in general, I find that's just an area that's lacking in healthcare, is the actual professionals who can help people to manage memory issues and attention issues and executive function issues on a day-to-day basis. Now, there's something called cognitive rehabilitation, but even that's not terribly well defined as to who does that or how effective it is. But that can involve like retraining sort of approaches or compensatory strategies and that sort of thing. But I find it's kind of hard to find people who provide that kind of therapy. So, would both of you agree that kind of that direct hands-on experience with or services in terms of improving cognitive function or compensating for cognitive issues or managing them on a day-to-day basis is somewhat lacking in our healthcare system?
Definitely, I would agree, and I agree with you as well, because the testing sometimes you are being basically given the bunch of papers that with very specific language that like 70% you don't even understand, right? Like for the parents, what they are talking about here in this testing. And then again, recommendations. I've seen very good evaluations where at least like 2 pages of recommendations are being made, and those are helpful ones, so written in a simple language that everyone can understand. including a student and obviously the teacher and then the therapist at school. But there are some that, yes, as you said, like it's a one paragraph and then there's no retranslation, from what they found, how to treat this, how to manage this. So I agree, there is a gap.
Right. I agree. So maybe, yeah. Go ahead. Sorry.
No, I agree 100%. Nothing to add.
Yep. So I think that's just.
I had the same problem when I was in school. I got A's on other things, but when the test came out, I got E's because I couldn't remember anything.
Yeah.
So I know it keeps going.
Right, and that's again just an issue with our healthcare system is that kind of cognitive health sort of is considered a lower priority, unfortunately, than physical or even mental health sometimes. So, Holly, I would certainly, if you want to contact us at some point to talk more and strategize more about, what we can do to help, I'd be happy to talk with you about that. So,
okay, I will reserve that for you.
Yeah. So, all right. Well, thank you so much, Dr. Ruprecht and Dr. Shaker, for a really thorough and expansive conversation. So we really appreciate that. And if anyone does have further questions, please visit our website at epilepsymichigan.org, or you can visit the national office's website at epilepsy.com, or give us a call at 1-800-377-6226. So thanks again to our speakers and for everyone for joining us today.
Thank you.
Thank you so much.
Thank you so much.
Everyone stay safe.